Topic of my presentation is impact of COVID-19 pandemic on tuberculosis. COVID-19 as well as tuberculosis are respiratory diseases of epidemiological concern, and both are the cursed duet that need urgent attention. The global response to COVID-19 has slowed the spread of the virus now, but it is continuing to cause serious short and long-term disruptions in major diseases, and tuberculosis is one of them. The threat of contagious infectious disease is constantly evolving due to the demographic explosion, travel globalization, and changes in human lifestyle that increases the risk of spreading pathogens. Tuberculosis and COVID-19 are, when they infect together, they cause serious consequences, and that we are going to see in this lecture. Tuberculosis, it is a major cause of death globally. It is a pandemic which is declared as a global health emergency by WHO in 1993. 1/4 of world's population, it is infected with tuberculosis, and these cases are mostly concentrated in 8 major countries, and India is one of them. As per the Global TB report, there are around 1.8 billion tuberculosis patients infected globally worldwide. And out of that, 10 million new cases are infected annually, and 1.5 million deaths occur annually as per the global report. 26% of the estimated new cases of tuberculosis are reported from India. This is published in the Global Tuberculosis Report 2019. SARS-CoV-2, it is the first novel coronavirus case which was described in Wuhan, China in late 19. And this pandemic has severely impacted the diagnosis of tuberculosis, and I'm sure this is the pandemic which quickly escalated the ladder and became arguably the largest outbreak in the world, and definitely it is the largest outbreak in this century. There are around 24 crore cases which were reported due to SARS-CoV-2 infection in the last 2 years. Objective of this presentation is what are the differences and similarities of tuberculosis and COVID-19, what are the immunological features, diagnostic, epidemiological and clinical characteristics of both diseases, what are the public health implications, and is the co-infection more serious, and how does the diagnosis affect one the other. There are some similarities between tuberculosis and COVID-19. Both are the respiratory illness. Both are having a significant epidemiological burden. Even though it is a huge burden of COVID-19 as well as tuberculosis is there, but in case of tuberculosis, this burden is slowly impacted, while in case of the COVID-19, it is rapidly impacted on the health status. Both these diseases, they spread through droplet nuclei, while in case of COVID-19, the infection can occur due to contamination of the contaminated surface, and when the droplets, when they are inhaled or when the person touches eyes, nose, mouth, so they also can be transmitted. So inhalation as well as touching the contaminated surface, both are the route of transmission in case of COVID-19. In both these diseases, the clinical features are same: fever, cough, breathlessness and malaise. These are the respiratory symptoms which is seen in both these diseases. There is a social predisposition, overcrowding, poverty and pollution, which is common to both. Risk factors like advanced age, diabetes mellitus, malnutrition, presence of chronic respiratory diseases, and in both these, the development of fibrotic damage in the lung, it is common to both conditions. There are some differences In case of tuberculosis, as we all know, the incidence is onset and it is a bacterial infection. COVID-19, the incidence is acute onset, while it is a COVID-19 infection, it is caused by the SARS-CoV-19 virus, and which is a beta coronavirus. The economic impact of both is huge. Diagnosis. In case of Mycobacterium tuberculosis, the standard culture method or the gold standard methods are the solid as well as the liquid culture methods and gene expert and line probe assays. In case of COVID-19, we use the nasopharyngeal swab and the oropharyngeal swabs, and we do the RT-PCR for diagnosis of COVID-19. Host response, it is similar. In both the conditions, the cytokines like interleukin-10, tumor necrosis factor alpha, interferon gamma, all the classes of interferon, that is class 1, 2 and 3 are involved. And T regulator cell plays a very important role in both the conditions, but the mediators which has a different pathways in these conditions. So cytokine storm, which this condition we came across COVID-19, but it is not seen in case of Mycobacterium tuberculosis. So this is how the immunomediators or the cytokines which play a different role in both the condition. So the important cytokines which are seen, which are produced due to these infections are the interleukin-10, tumor necrosis factor alpha and interferon gamma. Interleukin-10, it suppresses the phagosomal maturation, it suppresses the nitrous oxide production, and it can lead to the latent Mycobacterium tuberculosis infection and can lead to the progression of the disease and can convert into the acute case of tuberculosis. While it is consistent, interleukin-10, we all know, interleukin-10 and interleukin-6, both are associated with the severity of COVID-19 infection. In severe infection, the levels of these two interleukins are very high. Tumor necrosis factor alpha, which is a pro-inflammatory cytokines, and it is upregulated, and it upregulated Mycobacterium tuberculosis, leading to the increased stimulation of interleukin-1 and prostaglandins, which lead to the inflammatory manifestations of the tuberculosis. While tumor necrosis factor, again alpha, it is elevated, it is upregulated during the cytokine storm. ACE2 inhibitor, which has role in COVID-19, but as such, it is not reported any role in the Mycobacterium tuberculosis. SARS-CoV-2 virus, it binds to the ACE2 inhibitors, and these inhibitors are predominantly present in the lung and the kidney, where they are attached, these viruses get attached to this receptor, they are internalized, and the various immunomodulators or cytokines are secreted, leading to the, which activate the multiplication of the virus cycles. What happens exactly in co-infection? In co-infection, one disease augments the other. So, there is a transient decrease in cell-mediated immunity, which may lead to new infections like COVID-19 in case of tuberculosis, and it can lead to reactivation of latent infection of tuberculosis and can convert to active infection. Tuberculosis, it impairs the ability to mount SARS-CoV-2 specific immune response. So that's why in tuberculosis patient, the infection of the SARS-CoV-2 can be the severe. There's a shared dysregulation of immune response in COVID-19 and tuberculosis, suggesting dual risk posed by the co-infection, which worsen the COVID-19 severity, as well as favor the TB disease progression. There's a loss of structure of granulomine latent Mycobacterium tuberculosis due to the cytokine and T cell exhaustion. In COVID-19, there is a continuous stimulation of the T cell. These T cells get exhausted in case of severe COVID-19, and exhausted T cell, there's a decrease in the stimulation of the various cytokines like interleukin-10, tumor necrosis factor alpha. These are the pro-inflammatory cytokines and which keep the integrity of granuloma in case of tuberculosis, and due to the pro-attenuation effect, of this pro-inflammatory cytokines, the latent infection can be converted into active infection. So reactivation of the tuberculosis can occur also due to the inflammation, which is a characteristic of the COVID-19. There is a transient immunosuppression, there is a leading to the poor IgG response and delayed viral clearance, again leading to the severe COVID infection. So these are the factors which affect the severity of the disease whenever there is a co-infection occurs due to the tuberculosis and SARS-CoV-19 infection. What is the current and anticipated future impact of this disease? COVID-19 pandemic, it threatens to reverse the progress made in reducing the global burden of tuberculosis. There is a drop in reported number of people which are diagnosed with TB. So they dropped from 7.1 million to 5.8 million in 2019 and 20. There is a rise in the death from tuberculosis from 1.4 million cases which were reported in 2019 and it increased to 1.5 million in early 20. There is a significant reduction, that is 14% in 2020 and 9% in 2021 observed in number of drug-resistant tuberculosis patients which started on the anti-tuberculosis treatment. So, Stop TB Partnership Modeling Analysis, which assess the potential effect of lockdown on tuberculosis incidence and mortality over the next 5 years. There are the various studies which claims that the co-infection can cause a severe infection. As such, there is not a clear-cut guidance that the co-infection will lead to the severity of the disease. So this is the study this modeling analysis was carried out by United Nations International Agency for Development, USAID, along with Johns Hopkins University, and they carried out this analysis and they studied the effect of lockdown, and their analysis was, the summary of their analysis was there was 80% reduction in TB notification rate due to the non-availability of transportation facility. So the patient could not reach to the tuberculosis center. They could not get the drugs, anti-tubercular drug. There is a insufficiency of the anti-tubercular drugs, and the patients were on DOT therapy. They were given a 1 month medicine, and they were asked to take the medicine on home basis. That reduces the compliance of the patient, again development to the drug-resistant tuberculosis. And again, in their analysis, they have mentioned it could be the reduction in the TB notification rate. It could be due to the product of the many factors. It could be the reduced access to the diagnostic treatment, preventive services, and due to the pandemic, these patients were misdiagnosed as COVID-19 only, and as well as there was a global mask wearing and social distancing was followed in that era, and that could also reduce the TB notification. So reconfiguration of the TB service delivery which occur after the lockdown, after the complement of the lockdown. So that is a need as a result of shift in economic, political priorities towards COVID-19 containment. National effort to tackle tuberculosis were adversely affected during the pandemic. Most of the persons, staff working in the TB center, they lost their job, leading to poverty, further malnutrition, and malnutrition is again a major risk factor for tuberculosis, and that is again a risk factor for COVID-19. There are the debilitating effect on the TB services due to the limited access to the healthcare, anti-tuberculosis drug, as well as disruption of the treatment services. There are diabetes, extremes of the age, old age, diabetes, hypertension, and presence of chronic kidney disease or the chronic lung diseases were studied as a risk factor for COVID-19, but there is a very less material which is available where the tuberculosis was studied as a risk factor for COVID-19. So pre-existing tuberculosis disease and the underlying lung condition will definitely affect the clinical categorization of the COVID study. So there, as I said, there are various studies which were published that mean that the result of that studies means that the severity increases in the co-infection. So one of the study by Liu et al., he studied 36 patients of non-tuberculosis positive, and out of this non-tuberculosis positive 36 patients, he mentioned that 78% of the patients they develop the severe infection, and only 22% of the patient develop the mild infection. And this finding, similar findings are reported in other studies also, and this finding is statistically significant. Then, rate of disease progression was significantly faster if there is a co-infection and compared to the patient without tuberculosis. So, rate of disease progression, again, it is faster. And next is the development of the symptoms and being diagnosed as a severe disease. So, development of the symptom, it is faster if the patient is having a co-infection compared to the patient is having a single disease. Even tuberculosis, it acts as a risk factor. COVID acts as a risk factor for tuberculosis because COVID-19 itself or use of the various immunomodulators in the treatment of COVID-19 can cause dysregulation of the immune response and can convert the can lead to the tuberculosis progression. And this point, it points to the potential increase in tuberculosis cases post-COVID pandemic. Next important factor, why this co-infection causes the severe infection, it is a diagnostic dilemma. So, non-specific clinical features and non-atypical radiological finding for tuberculosis can lead to the missing of the diagnosis. So, again, this was reported in various studies. I have quoted one study from Singapore, Batham et al. He reported the effect of co-infection considering the atypical radiological finding. He reported 4 COVID-19 positive cases with atypical radiological finding like ground glass opacity, multifocal patchy consolidation, peripheral interstitial changes. Even though the patients were confirmed COVID-19, they were given the treatment, but they didn't respond very well. And they lead to the long COVID disease, which is one of the manifestation of co-infection. And in this long COVID disease, it is always mandatory to consider the other pulmonary pathologic conditions like tuberculosis, which can cause the atypical radiological finding and which helps in the thinking of that the patient is, along with the COVID, patient has some other disease. Then there are some screening tests which are used like the tuberculin screening test, tuberculin skin test and interferon gamma release assay. They are used for the screening test in some of the places. And the result of this screening test is affected in case of the co-infection because of the increasing, it can also be affected like increasing a low blood lymphocyte count, which is seen in the COVID-19 infection, high body mass index, and immunosuppressive therapy, which is given to reduce the inflammation of COVID-19. So, they give the false negative result. Excess of inflammatory markers, which is seen in the cytokine storm. So, that is also affect the result of this screening test. If the patient is within few days of exposure of SARS-CoV-2, there is a high CRP level and low peripheral blood lymphocyte count, and that also can contribute to the false negativity of this screening test. National Tuberculosis Guideline in India is that a diagnosis of COVID-19 does not exclude the underlying tuberculosis or underlying any pulmonary condition. Especially in tuberculosis endemic setting like India, if the acute COVID-19 illness, if it extends beyond 2 weeks, it is imperative to consider tuberculosis as a concomitant infection. So as per the guideline of National Tuberculosis, any fever or cough that extend beyond 2 weeks, they should be investigated for tuberculosis. So the Ministry of Health and Family Welfare India has released the advisory on 26 August 20, stating that the prevalence of tuberculosis among COVID-19 patients, it is 0.37 to 4% and recommends the bidirectional screening for COVID-19 and tuberculosis. So as per the guidelines, patients of COVID-19, which is having a long COVID, symptoms more than 2 weeks, they should be screened for tuberculosis. Simultaneously, the patients suffering from tuberculosis, having some atypical findings, atypical clinical features, they should be screened for tuberculosis. So tuberculosis screening, it is mandatory in influenza-like illnesses. Tuberculosis screening, it is mandatory for all SARI cases. What is the treatment outcome? So the success rate and percentage of the death are concerned. The national scenario shows the fatality in TB COVID comorbid patient in 2021 was more than twice that of TB patient without COVID. This is published by Ministry of Health and Family Welfare in TB report 22. And as per that report, the success rate in case of COVID-19 positive patient, it is 82% where there is a co-infection, and it is 88% if the patient is having only tuberculosis. Similarly, the death rate, it is 9.33% if the patient is co-infected, compared to if the patient is having alone tuberculosis, then the death rate is very less, almost half than that, that is 3.55%. So to conclude, tuberculosis and COVID-19 are linked bidirectionally. TB is associated with 2.1-fold increase in risk of severe COVID-19 disease. Co-infection is suspected in patients with severe features, prolonged clinical course, and atypical radiographic finding. Temporary immunosuppression induced by tuberculosis may increase the susceptibility of the patient to COVID-19, and COVID may in turn also increases the susceptibility to tuberculosis. A diagnosis of COVID-19 does not exclude underlying tuberculosis, and in tuberculosis endemic setting, if the acute COVID-19 illness extends beyond 2 weeks, it is imperative to consider tuberculosis as a concomitant infection. More evidence is needed to know the potential of COVID-19 in reactivation of latent tuberculosis infection. Timely initiation of treatment should be the priority. The impact of COVID-19 on active TB is manageable with proper care, effective infection control practices, and use of proper personal protective devices. So robust integrated effort from policymakers, national government, NGOs needed to reduce the burden of tuberculosis, to maintain the continuity of essential services for tuberculosis, and accelerating the surveillance of vulnerable population and asymptomatic contact to identify high-risk group and performing high-quality molecular epidemiological research to reach the goal of WHO's End TB strategy and Government of India's National Strategic Plan to eliminate tuberculosis by 2025. COVID-19 pandemic has reversed the years of progress made in the fight of tuberculosis. As per the WHO World Health Organization report in 20, there are increase in tuberculosis cases, tuberculosis death. There is decrease in the fewer people who were diagnosed and treated and provided the tuberculosis prevention treatment. There is a decrease in the number of resources and essential TB services and the financial finances for doing the tuberculosis research and development. These are the references.